Today we're going to discuss how to conduct a respiratory assessment. Keep in mind that your patient's chest should be bare, not obstruct listening and palpating your chest. You'll start out by observing your patient's respiratory rate. Don't let your patient know that you're counting. Your rate should be between 12 to 20 breaths per minute. Check their rhythm. Is it regular, irregular? Are they breathing deep or too shallow? Check their oxygen saturation. It should be between 90% and 98%. Are they on room air? Are they having to have supplemental oxygen? You're going to check your chest configuration. Is it symmetrical in movement? And it should be twice the width as it is deep. Do they have any retractions that you can notice from previous trauma? And you'll have to check for chest expansion. To do that, you'll place your thumbs about midline, tell your patient to take a deep breath in and out. Your thumbs should move symmetrically in and out. After that, you're going to percuss. To do that, you're going to use your finger and go between each rib and your intercostal space. You should get a low pitch sound that is hollow. You'll also observe to see if you have any problem or any accessory muscle use. Are they diaphragmatic breathing? Are they using any neck muscles? Or are they in the tripod position? To palpate, you'll start at your clavicles and go from side to side, go into your laterally to your mid-axillary line down to your 12th rib. You're going to palpate for any tenderness or masses that your patient reports. To listen to your patient's lungs, keep in mind the right side has 3 lobes, the left side has 2. And you'll do a 10-point auscultation. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Each time you'll ask your patient to take a deep breath in and out. You're listening for the vesicular sounds, which are a low soft pitch that you'll hear throughout the majority of your lungs. When you're listening over the trachea, you're going to hear high-pitched sounds, and your main stem bronchi are going to be a medium pitch. You're also going to be listening for any adventitious breath sounds, such as crackles, which are a wet sound. They're also known as rails. You will also be listening for any wheezing that's noted. It could be indicative of asthma, inflammation anywhere within the lungs. You can also hear bronchi. Sometimes that can be cleared up. You just ask your patient to cough, and typically that'll clear it up. If you hear stridor, it'll be a very loud crowing noise. That is indicative of obstruction, severe inflammation, and really you won't have to have a stethoscope to hear that. It's very audible without the stethoscope. If you hear a pleural friction rub, it sounds like 2 sheets of sandpaper being rubbed together. That's from inflammation of the membranes of the lung and the lining rubbing together. If you have diminished breath sounds, that's going to be from a possible pleural effusion, if your patient's overweight, any atelectasis, or pneumonia. And that concludes our respiratory assessment.